The United States spends roughly twice what other large, wealthy countries spend on healthcare per person every single year, not somewhat more. Twice! Part of why that number doesn't cause more outrage is that healthcare is, by design or by accident, one of the most complicated products you will ever buy. You don't shop for it the way you shop for anything else. Almost every wealthy country agrees on the destination, coverage for everybody. Where they disagree sharply is the route. Some use single-payer systems, some regulate private markets. The US took a different road entirely. This part isn't uniquely American. As far back as anyone has measured it, healthcare spending has gone up everywhere, every year. The only real question is by how much, and who ends up paying for it. Globally, healthcare spending doubled over 2 decades, hitting $8.5 trillion by 2019. That is not inflation. That is an entire industry outgrowing almost everything else on the planet. $8.5 trillion works out to 9.8% of the entire world's economic output. Put differently, nearly 1 out of every $10 produced on Earth that year went toward keeping people treated. Every country in that count is fighting the same rising tide. But the United States is losing that fight worse than almost anyone else. Not because Americans get sicker, but because the system is worse at controlling what things cost. Here's the structural detail most people miss. The US system is built to cure you after you're sick, not to keep you from getting sick in the first place. That one design choice explains a lot of what follows. There is no such thing as the American healthcare system. There are thousands of them running in parallel, and which one you get depends on your insurance status, your zip code, and the provider network sitting nearest to you. And this doesn't only frustrate the people paying the bills. Ask the physicians. The people delivering the care are navigating the same maze as the people receiving it, and they don't love it either. So here's the question worth spending the next stretch of your time on. Why do healthcare costs in the US keep climbing faster than everywhere else? And is there anything that actually stops it? Start with where this began. In 1960, healthcare made up about 5% of the entire US economy. 5 cents on every dollar, a rounding error compared to today. By 2020, that number had climbed to almost 20%, not a rounding error anymore. 1/5 of the entire American economy, rebuilt around a single industry. Translate that into your own spending. For every dollar that moves through the US economy, close to 20 cents of it is now headed toward healthcare, one way or another. The easy explanation is inflation. Everything costs more than it used to, so of course healthcare does too. That explanation is comforting. It's also incomplete. Healthcare costs don't only rise with inflation. They rise faster than the economy that's supposed to be paying for them. That's the actual mechanism behind why it eats a bigger slice of the pie every year. Here's the part that should bother you more than it does. The US spends more per person on healthcare than any other high-income country on Earth and still has a lower life expectancy than most of them. Twice the price. Worse outcomes. Buy a product with that pitch anywhere else in your life and you'd call it a bad deal. In healthcare, it's the baseline. And it isn't because Americans visit the doctor twice as often or get twice as many procedures. People in the US use roughly the same amount of healthcare as people in other wealthy countries. The difference isn't how much care you get. It's what you're charged every time you get it. Same visit, same scan, same procedure. A bigger bill. So where does the extra money actually go? Follow it, and it lands in 2 places above all others: hospitals and doctors. That's the core of the gap between US spending and everyone else's. In 2019, hospitals, physicians, and clinical care alone made up more than half of all healthcare spending in the country. Not drugs, not insurance overhead, care delivery itself. There are only 2 structural levers here, mathematically. You reduce how much care people receive, or you reduce the price charged for each unit of it. Everything else is a variation on those 2. And since usage isn't the difference, that leaves price. If the US wants to close the gap with everyone else, the lever that matters is the price tag, not the quantity of care. Here's where most explanations stop and where they go wrong. Hospital prices are too high. Drug prices are too high. True statements. But they're symptoms. They describe what's expensive. They don't explain why it got that way. One actual cause, not a symptom, is how fragmented the American insurance system is. There isn't one system to fix. There are countless overlapping ones, each with its own rules, its own gaps, its own pricing logic. Under that fragmentation, 2 Americans with the same condition can live in completely different financial universes. One has comprehensive, affordable coverage. The other has almost none. Same country, same disease, different bill entirely. If you're healthy, this fragmentation barely touches you. Healthy people spend a small share of their income on healthcare, almost by definition, because they aren't using much of it. Get sick though, especially while sitting on a high deductible private plan, and that share balloons. The system that felt invisible while you were healthy becomes the largest line item in your life. In 2020, more than 11% of the US population had no insurance at all, and that number wasn't spread evenly. It broke down sharply along racial lines. Here's the number that should actually alarm you. 51% of Americans said they had delayed or skipped medical care because of cost. Not because they didn't need it, because they couldn't afford it. Narrow that to households earning less than $40,000 a year, and the number jumps to 63%. Nearly 2 out of 3 people in that bracket are rationing their own healthcare. Having insurance doesn't fully solve it either. 46% of insured adults reported difficulty affording their own out-of-pocket medical costs. The card in your wallet is not the same thing as affordability. The World Health Organization made this explicit in a 2021 report. Universal coverage limits catastrophic health spending, not eliminates it entirely, limits it. Hold on to that distinction. Where the lack of universal coverage does the most damage isn't emergency care, it's prevention. When cost becomes the gatekeeper, the first thing people give up is the care that would have stopped a small problem from becoming a large one. Picture someone with no insurance or barely any who feels a dull pain on the right side of her abdomen. A doctor's visit would run her about $120, so she doesn't go. She works through it instead. 3 months later, she's in the emergency room. What started as a manageable infection is now a burst appendix, and the bill for treating it lands around $60,000. Had she gone in on day one, the same infection could have been treated for about $100. Same person, same illness, a 600-fold difference in cost, decided entirely by whether she could afford the first visit. This is where a mechanism called cost shifting kicks in. When providers can't collect from patients who can't pay, they don't just absorb the loss, they raise prices for everyone else, especially people with insurance, to cover the gap. Providers plan around the fact that something like 30% of billed charges may never get collected at all. That unpaid share doesn't vanish, it gets rebuilt into the price charged to whoever is left holding a payable bill, which means the final number on your bill was never really about your treatment, it was about your insurance status, layered on top of everyone else's unpaid bills, layered on top of where you happen to be treated. And because fragmentation means Americans rarely keep the same insurer for life, insurers have little reason to invest in keeping you healthy long term. Why pay to prevent a disease in a customer who, statistically, will be someone else's customer by the time it shows up? Remember the no-menu restaurant I told you about, the one where you eat first and get handed a bill written in rules you never saw? Here's the detail most people skip past. You did not even choose that restaurant. 54% of Americans get their health insurance through their employer, which means the single most consequential financial contract in your life was picked, mostly, by someone in HR, comparing spreadsheets back in October. Was the American healthcare system ever actually built to behave like a free market? Look at how prices get set, and the honest answer is no. Capitalism, in theory, runs on one condition: buyers and sellers negotiating directly, with real information and the real ability to walk away. Remove any one of those three things and you do not have a market anymore. You have something else, wearing a market's clothing. In an actual market, you negotiate your own price. In this one, an insurance company negotiates it for you, months or years before you ever get sick, in a room you were never invited into. By the time you show up with a broken wrist, the number was already settled by two companies arguing over a contract that has nothing to do with your wrist specifically. Then there's the network. Your insurer keeps a list, a narrow one, of which doctors and hospitals count as in-network and which do not. Step outside that list, even by accident, even because the in-network hospital happened to assign you an out-of-network anesthesiologist while you were unconscious, and the protection you thought you had does not apply. apply. Here's a fact that would sound insane in almost any other industry. Most patients walk into treatment with no idea what it will cost. Not a rough idea. No idea. You find out the number weeks later, printed on a piece of paper after the decision to treat you has already been made and carried out. A functioning market runs on one requirement above every other. You have to know the price before you buy. Walk into a grocery store and try paying without ever seeing a price tag on anything. That, structurally, is what happens most times you walk into an emergency room. Here's the part that tends to surprise people. It is not only patients left in the dark. Ask the billing office at your own doctor's practice what your visit will cost, and often they cannot tell you either, not because they are hiding it, but because they genuinely do not know yet. That's because the people treating you do not set the price. The rate for your visit was negotiated separately, company by company, by executives who have never met you, and the doctor billing you is, in practice, the messenger for a figure decided somewhere else entirely. Layer deductibles and out-of-pocket maximums on top of that fog. Even handed a complete list of every possible charge, a hospital still would not know whether you have hit your deductible for the year, where you stand against your out-of-pocket maximum, or whether your particular plan charges a flat copay or a percentage. The bill is not a fact, it is a forecast. A large share of American medical care runs on something called fee-for-service. Every single action taken on your body gets its own line item, its own separate charge. The gauze, the consultation, the extra 5 minutes. Your doctor, under this model, is not billing for your care. Your doctor is billing for a list of individual actions performed. The surface level explanation for what comes next is that doctors are greedy. That is the story people reach for. It is true in a handful of cases, but it is surface level. And here is the deeper question. What happens when you build a payment system where doing more, quite literally, pays more? Economists call it provider-induced demand. Was that system ever designed to reward restraint? Look at the incentives. It was not. Layer a second incentive on top of the first. Physicians in the United States practice inside one of the most litigious medical cultures on the planet. Order fewer tests, and if anything goes wrong later, that decision becomes evidence in a malpractice claim. Order more tests, and almost nothing you did can be used against you. Separate from the lawsuits entirely, there is a more human fear driving the same behavior, the fear of missing something. No physician wants to be the one who sent a patient home with a diagnosis that turns out wrong. So the tests get ordered, not for money, not for court, but to avoid ever having to live with the alternative. Insurance companies know all of this, and since there is no real price competition left to rein in spending, they reach for two other tools instead, denying certain claims outright or requiring prior authorization before they will agree to pay for a procedure at all. Prior authorization sounds like paperwork. Functionally, it is a checkpoint. Before your physician can act, an employee at your insurance company, someone who has never examined you, decides whether the treatment your own doctor already recommended is allowed to happen. To be fair to the insurers, for one sentence, most physicians are making the right call for their patients. But some of these denials do target procedures that genuinely were not the most effective option available, which means the gatekeeper, frustrating as it is not always wrong. It is, however, never neutral. Which brings you to the people who look at all of it, the no-menu restaurant, the narrow networks, the invisible prices, the incentive to do more, and conclude the entire structure needs to be replaced, not patched. Not everyone in this camp agrees on the blueprint. Nearly everyone agrees the current one has to go. The most discussed replacement is Medicare for All, a system that would remove for-profit insurance companies from the equation entirely and replace them with a single government-funded health plan covering everyone in the country. Its supporters make one clean argument. If the stated goal is coverage for everyone at the lowest possible system-wide cost, then a single public payer is, in their view, the most direct route to that destination. Not the only conceivable route, the most direct one. President Biden did not take that route. His administration chose the narrower path instead, expanding the Affordable Care Act, working through the existing patchwork of private insurers rather than replacing it. Where the two parties do find common ground, oddly enough, is price transparency, not universal coverage, not who pays for what, the far narrower idea that you should be able to see a price before you agree to anything. That common ground actually produced legislation. The No Surprises Act took effect in January of 2022, aimed squarely at the exact scenario from the narrow network vignette earlier, the in-network hospital, the out-of-network doctor you never chose and never met. Under the law, if you end up treated by an out-of-network provider without meaningfully choosing to be, most of that surprise bill can no longer legally land on you. Instead, you are held harmless, on paper at least, while your insurance company and the doctor who treated you argue between themselves over how much that doctor actually gets paid. You are removed from a negotiation you were never equipped to win in the first place. Here is the part that should unsettle you more than any single statistic in this video. Economists and health researchers still do not fully agree on what is driving these costs. Not because nobody has looked, because the system has so many interlocking parts that isolating one root cause turns out to be genuinely difficult. Some of the current transparency push is almost embarrassingly modest in concept, require hospitals and doctors' offices to post their prices on their own websites the same way a restaurant, any restaurant, posts a menu. So no, there is not one single fix waiting to be discovered, no bill that unwinds cost, access and quality all at once. There are several different levers moving in several different directions, and most serious proposals only pull one or two of them. If this is the kind of breakdown you have not seen laid out this clearly before, subscribe. I put out exactly this regularly. The incentives, the numbers, where they actually lead, nothing else. No motivation, no fluff. Now take everything you have learned so far about the no menu restaurant and remove the one freedom you thought you still had, the freedom to pick which restaurant you walk into. In a medical emergency, you do not call an ambulance company. You call 911, and 911 decides who shows up. In America, that decision is a financial gamble you never agreed to make. Start with this. 71% of ambulance providers in the United States do not take your insurance at all, not your specific plan. Insurance, broadly, as a concept. A large majority of ambulance rides begin with a company that was never going to bill your insurer in the first place. The consequence shows up on the other end. 79% of patients who take an ambulance are exposed to a surprise bill, a charge that arrives after the fact, calculated by a company you did not choose, for a service you never got to shop around for. Put a number on it, and put a name on it too. Marcus, 28 years old, chest pain at 2 in the morning, calls 911 because that is what you are supposed to do with chest pain at 2 in the morning. The average surprise bill following a ride like his comes out to around $450 after whatever his insurance was willing to cover. Nobody asked him to sign anything. It arrived, in the mail, 3 weeks later. Here is why $450 is not a small number to the people it lands on. Nearly 4 in 10 Americans could not cover a surprise $1,000 expense without borrowing the money first, from a credit card, a relative, or a payday lender. The ambulance bill alone runs close to half that threshold. Then the pandemic arrived and pressed down on an already strained system. Call volumes climbed. Protective equipment became expensive and scarce. Ambulance operators, most of them running on thin margins to begin with, absorbed a financial hit at the exact moment demand for their service spiked hardest. Go back further and the picture does not improve. The Government Accountability Office found that back in 2010, the median cost of a single ground ambulance transport was $429. That figure hides a wide range underneath it, anywhere from $224 to $2,204, depending entirely on where you happen to need one. That word, where, is doing more work than it should have to. Ambulance pricing in the United States is not a national number. It is closer to 50 separate pricing environments, and sometimes several distinct pricing environments stacked inside a single state, with no coordination between any of them. By 2016, the average charge for an emergency ground ambulance ride was $824 in Georgia, $752 in New York, $930 in Texas, and $557 in Florida. 4 states, 4 completely different answers to the same emergency. Here is what should genuinely bother you. That variation does not stop at the state line. It repeats itself inside a single state, sometimes inside cities close enough to drive between on a lunch break. In Lake City, Florida, the average charge for a basic ground ambulance transport was $463. 2 hours west, in Tallahassee, the average charge for the same category of service was $680, more than $200 higher, for what is, on paper, the identical product. Miami's average came out to $630. Tampa's landed at $590. This is where Marcus's story stops being average. His ride happened to come from an out-of-network operator working at Tampa suburb, and his actual bill landed closer to $1,200, more than double his own city's reported average. Averages describe the middle of a distribution. They say nothing about what happens to you, specifically, out on the tail end of it. What decides where you land on that distribution is not your condition. It is a checklist that has nothing to do with your body, the type of ambulance dispatched, the distance covered, the specific services documented on the ride, which state and city you happen to be standing in, and whether the operator answering the call was a public agency or a private, for-profit company. That last variable matters more than people realize. Emergency medical services in America are run 3 different ways, sometimes within the same county: municipal departments funded by tax dollars, private for-profit companies working under contract, and volunteer squads funded entirely through community donations and grants. Which brings you to Westfield, New Jersey, where the volunteer rescue squad runs entirely on grants and donations from residents and local businesses. Every dispatcher, every EMT is a volunteer. There is no bill waiting for you at the end of the ride, not because the service costs nothing to run, but because the town decided, collectively, to absorb that cost before it ever reaches your mailbox. Which raises the obvious question you should be sitting with right now. If Westfield can do it, why doesn't every town look like Westfield? I am not answering that yet. Take a volunteer rescue squad in a town like Westfield, New Jersey. It runs on donations and grants from the businesses and residents around it, and when the ambulance shows up, there's no bill waiting for you at the door. The dispatchers, the EMTs, the drivers, all volunteers. In a labor-intensive business, labor is almost always the biggest expense. Remove the payroll, and you remove most of the reason ambulance rides cost what they cost. That model works beautifully in a town with money to spare and neighbors willing to give their time for free. It falls apart somewhere else. A dense city with constant call volume burns out volunteers fast, and a low-income town doesn't have the donor base to keep the lights on, ask for free labor and steady community funding in a place with neither, and the volunteer model quietly stops being an option. When a town can't recruit enough volunteers or can't raise enough in donations, someone still has to answer the phone at 3 in the morning. The town's alternative is almost always to contract with a private ambulance company or fold EMS into the police or fire department payroll. Either way, the free version disappears and a bill enters the picture for the first time. That's the door through which most surprise ambulance bills walk in. Researchers who traced who actually sends these bills found the pattern lines up overwhelmingly with private for-profit operators, not with volunteer squads, not with municipal services. The free ride and the 4-figure invoice come from 2 entirely different business models. Here's the mechanic underneath all of it. A surprise bill isn't really about the ambulance. It's about who gets to choose. You choose your restaurant. You choose within reason your surgeon. Nobody having a heart attack gets to shop around for a favorable rate before the ambulance arrives. Remove the choice and you remove the only thing that normally keeps a price honest. Once that provider isn't in your insurance network, which for an ambulance is closer to the default than the exception, there's no contract setting the price. Legally, they can bill you close to whatever the ride cost on paper, not because anyone is breaking a rule, because in that specific gap, there isn't one. To measure how large that gap actually is, one team pulled insurance claims data from a large national plan, covering rides taken between 2013 and 2017. They weren't counting bills patients definitely received. They were counting the ones that were legally possible given what insurance already paid out. The number that came back for a ground ambulance ride, about $450 on average, left over after insurance had already paid its share. That's not the sticker price of the ride. That's the leftover balance a for-profit provider remains free to send you. Now compare that to a helicopter. The same study put the average potential surprise bill for an air ambulance at $21,700 per ride. Not a typo, nearly 50 times the ground figure, for a service that mostly differs from a truck by how it gets to you. Here's what nobody stops to ask though. If the air ambulance bill is 50 times worse, why does most of the outrage online focus on ground ambulances? Because ground rides happen roughly 55 times more often than air ones. Rare and catastrophic gets attention. Common and merely bad gets ignored. And ignoring it is the mistake. Run the math across that same 4-year window, and total potential surprise billing from ground ambulances outweighs the total from air ambulances, even though each individual air bill is dramatically larger. Frequency beats severity once you start adding up the damage across an entire country. Air ambulance billing isn't standing still either. Over that same stretch, the potential surprise bill for a helicopter ride climbed by about 15% a year. At that rate, the gap between ground and air narrows fast, even with ground still carrying the larger total. You'd assume that kind of growth means more people in remote places finally getting airlifted to care. Between 2012 and 2017, more than 100 new helicopter bases opened across the country. Researchers who looked into it found plenty of those bases weren't filling gaps in rural coverage. They were landing in places that already had one, competing for the same calls. Was this ever supposed to work like a normal market where more suppliers push prices down? A 911 dispatcher decides who responds, not you. And when you look at the incentives clearly, the answer is no. Adding competitors doesn't lower your price if you never get to pick between them. Consumer advocates interviewing patients afterward kept hearing the same complaint. People who'd been flown by helicopter later convinced it hadn't been necessary. Not because the situation wasn't serious, because by the time the helicopter landed, loaded them, and took off again, a ground ambulance might have reached the hospital in roughly the same time. That disagreement rarely stays a private one. It turns into a fight with the insurance company over medical necessity, with the patient stuck in the middle, holding a bill that depends entirely on which side wins the argument months after the ride itself is over. Here's a cost structure most people never consider. An ambulance sitting idle in a garage, ready for your emergency, isn't generating revenue. Even a well-run system can only spend, at best, around half its time on actual paid calls. The rest of the hours are the price of being available at all. Hospitals file detailed cost reports that justify their Medicare payments. Ambulance providers, by their own trade association's admission, mostly don't. It remains one of the only corners of American healthcare where nobody is required to document what a ride actually costs to produce. Without that documentation, nobody outside the industry can tell the difference between a company charging a fair markup and one charging whatever the market will bear. A former healthcare attorney at a consumer advocacy group put it plainly: without the underlying cost data, there's no way to know how much of any bill is profit. That uncertainty gets sharper once you notice who owns a growing share of these companies. Private equity firms have been buying into ambulance operators, and a business built around opaque, out-of-network billing is exactly the kind of asset that pattern tends to attract. Meanwhile, on the insurance side, most private plans still list ambulance providers as out-of-network by default. No negotiated rate exists between the two parties before the ride ever happens, which is unusual for a service nearly everyone will need at some point in their life. You'd expect an ambulance company to want an in-network deal, steady patients, a set rate. Except under the current reimbursement setup, staying out of network and billing the full, undiscounted price directly often pays better. Why sign a contract that caps what you can charge? The ambulance industry's own trade group rejects that framing entirely. Take Houston. If the city itself runs the only 911 ambulance service in town, there's no competing provider to compare it against. So, in their view, calling that arrangement out of network misdescribes what's actually an insurer refusing to pay the rate the city has already set. It isn't only private insurers accused of underpaying. A report commissioned by the American Ambulance Association concluded that Medicare reimburses ambulance providers below their cost of service, and Medicaid, true to form, pays even less than Medicare does. The surface-level explanation for why private pay bills run so high is that providers are covering the shortfall from Medicare and Medicaid patients by charging everyone else more. That's the story you'll hear repeated constantly. It's surface level though. The deeper question is whether anyone has actually found evidence for it, and researchers who went looking say they haven't. Zoom out, and there's a design reason out-of-pocket ambulance costs exist at all. Free healthcare at the point of use invites overuse, and nobody wants an ambulance dispatched for a routine stomachache when it could be treating someone in cardiac arrest instead. The intended balance is narrow, a fee high enough to make you think twice before calling for something minor, low enough that calling for something real never threatens your finances. In practice, American ambulance billing regularly clears the second bar without ever meeting the first. Compare that to Australia, where ambulance fees range from nothing at all in some states and territories to over 1,000 Australian dollars in others, depending entirely on where you happen to live when you need one. The states charging nothing get exactly the overuse problem the fee was supposed to prevent. Residents call ambulances for complaints that clearly don't warrant one, straining a system designed for emergencies, precisely because there's no cost attached to discourage it. So the government runs public campaigns instead of charging a fee. Ambulance Tasmania, for instance, publicly reminds residents that a 3-day cold or a sprained wrist doesn't need a 911 response. Save 000 for saving lives, as the campaign puts it, because the price signal isn't there to say it for them. Here's where it gets genuinely strange. Ambulance billing is one of the rare issues where Democrats and Republicans, the House and the Senate, and the President have all agreed something is broken. Bipartisan agreement on the diagnosis. Almost no legislative movement on the cure. The one concrete step came in the Bipartisan Budget Act of 2018. It ordered every ambulance provider billing Medicaid to report their cost data at least once over a 4-year window. The first real attempt to build the documentation the industry had never been required to produce. Congress didn't hand over that mandate for free. The same legislation authorized what are called extender payments, added Medicare funding tied to the region a provider serves, extended for 5 years as the trade for finally handing over the cost data lawmakers had been asking for. Individual states have tried filling the gap themselves, passing laws to shield residents from surprise ambulance bills. The pattern that follows is fairly consistent. The industry challenges the law in court soon after it passes, and progress slows to the pace of litigation. One exception arrived through the pandemic. Under the CARES Act, any provider that accepted federal COVID relief funding was barred from balance billing a patient suspected of having the virus. A narrow protection, but proof that Congress can act quickly when it decides to. That narrow fix sat inside a much larger reckoning. The pandemic didn't create the inequities running through American healthcare. It made them impossible to look away from, emergency services included, and left the country asking whether unregulated, for-profit emergency response was ever the right design to begin with. Now here's where the story stops being about the ambulance ride and starts being about the decision you make months before you ever need one. Because it turns out most Americans, given a stack of health insurance options, pick the wrong one for themselves. Researchers at Carnegie Mellon tested that claim directly, studying almost 24,000 employees at a single Fortune 100 company, comparing the plan each person picked against the plan that would have actually served them best. 61% of them, the majority, had chosen the wrong plan for their own situation. Not a rounding error, not a handful of outliers. Most people in the sample left money on the table while choosing between options sitting right in front of them. The researchers priced out what that mistake was worth. About $372 a year on average for each employee who picked wrong. Roughly 2% of salary, disappearing every year into a decision most people made once and never revisited. Multiply that kind of mistake across the country and the totals climb fast. By 2018, healthcare costs made up more than 8% of the average American household's total spending, an increase of roughly 37% since 2004. Ask why so many people choose badly, and the answer starts with vocabulary. Surveyed year after year on the most basic terms, premium, copay, deductible, only about a third of people can correctly define all three. You cannot optimize a decision built entirely out of words you don't understand. Ask a room full of adults to define premium, copay, and deductible, only about 1 in 3 gets all three right. Not because they are careless, Because insurance is written to be misread. Here's the actual failure. Plans list features, deductible, copay, out-of-pocket max, but nobody translates those features into a dollar number. You can see the parts. You can't see what happens when you break your leg. The premium is the toll you pay to stay on the road, whether you drive or not. Every month, healthy or sick, that number leaves your account first. The deductible is the second toll. You pay it entirely yourself, in full, before the insurance company contributes a single dollar toward your care. Most people pick a plan by staring at one number, the deductible, usually, and ignoring the other 11 months of the year where that number barely matters. There's a reflex that says expensive means better. Researchers found people shopping for health insurance the way they'd shop for a hotel room, assuming the higher price bought higher quality. It doesn't. It buys different cost sharing, not better doctors. So researchers ran an experiment almost nobody in the industry bothers to run. A tool showing, for every plan, what you'd actually spend across a full range of medical scenarios, not the sales pitch. Plotted as a simple graph, some plans sat visibly above others. Employees using the tool ended up, on average, spending less money over the year than the ones left to guess. That idea didn't stay in a lab. Some employers and a handful of state-run Affordable Care Act marketplaces now offer their own version, a calculator instead of a guess. If you're managing a serious condition, the calculator isn't the part that matters most. What matters is whether the specific doctors keeping you alive are even inside the network you're about to buy. Here's the quiet number that makes all of this worse. Only 20 to 25% of employees change their plan in a given year. Most people pick once and stop looking. Pick the wrong plan in year one, on a purely financial basis, and the mistake doesn't cost you once. It compounds silently for however many years you don't bother to switch. If you're shopping the marketplace alone, there are trained navigators whose entire job is walking you through the application and the plan comparison for free. Almost nobody knows to ask. Zoom out and the trend line explains the whole chapter. Healthcare spending was 6.9% of US GDP in 1970. By 2019, it had climbed past 17.5%. Employer deductibles alone more than doubled in under a decade. $869 in 2008, $1,808 by 2017. Between 1984 and 2020, the average American household income rose 27%. Food spending rose 155%. Housing rose more than 160%. Medical spending, out of pocket, rose more than 390% in that same stretch. Not the total bill, just the part you personally had to cover. Nothing else on that list comes close. That number is why high deductible plans have quietly become the default across employer coverage. Lower premium, sure. But it assumes you have the cash sitting there, ready the day you need it. People earning under $40,000 a year are more likely to end up in the costlier plan and less likely to ever switch out of it, even when switching would have saved them money. None of this makes the high deductible plan a scam. If you're relatively healthy, paying a lower premium and rarely touching the deductible, it is, mathematically, the better long-term deal. The math only assumes a body that stays cooperative. Ask the economists what actually fixes these, and the answer isn't a better calculator. It's removing the layers of cost sharing entirely and replacing them with a menu simple enough that you don't need one. Until that happens, you get metal tiers. Bronze plans cover 60% of costs at time of service, you cover the other 40. Platinum covers 90%, you cover 10, for a much higher monthly premium. The names do the damage. Bronze, silver, gold, platinum. It reads like a ranking of quality. It isn't. It's a ranking of how the same bill gets split between you and the insurer, nothing more. In July of 2021, President Biden signed an executive order aimed at standardizing exactly this comparison on healthcare.gov. Starting in 2023, a few states didn't wait for Washington to move.